Therapeutics of Bronchial Asthma and COPD, Chronic Obstructive Pulmonary Disease. Objectives of today's lecture, as per our respiratory system blog, is write the prescriptions for different cases of bronchial asthma, including acute asthma, chronic, and status asthmaticus, and chronic obstructive pulmonary disease. And second one is mention test required to monitor therapy of bronchial asthma. In the previous lectures, we already discussed the drugs which are used in the treatment of bronchial asthma and COPD, including bronchodilators and anti-inflammatory drugs. We already discussed each drug in the category of bronchodilator and the anti-inflammatory, which are used in the management and treatment of bronchial asthma and COPD. There is one term, status asthmaticus. As we know, acute and chronic. But what do you mean by status asthmaticus? Status asthmaticus is an older, less precise term for what's now more commonly known as acute severe asthma, or also known as severe asthma exacerbation. So status asthmaticus means acute severe asthma or severe asthma exacerbations. Now first, we will discuss the dosage form and drugs which are used in the management of acute severe exacerbation of asthma in emergency department. We can say the management of status asthmaticus in the emergency department. So it will cover the objectives of the prescription which are used for the management of status asthmaticus. As we know, the first preferred drug in the management of asthma includes beta adrenergic agonist. Amongst the beta agonist, as we discussed in our previous lecture of bronchodilator, there are two types of beta agonist, short acting and the long acting. Short acting beta agonist examples are albuterol, duration of action here about 4 to 6 hours. The another name of albuterol is salbutamol. And example of long acting beta agonist is salmeterol. which is having duration of action near about 12 hours. Generally, inhaled beta agonists are preferred because quick effect to the bronchioles, and we can say targeted drug delivery to the bronchial smooth muscle. Fast action. Albuterol or salbutamol nebulizer solutions are used, which are available in the concentration of 5 milligram per ml, 0.63 milligram per 3 ml, 1. 1.25 milligram per 3 ml, 2.5 milligram per 3 ml. There is two categories of patient: more than 12 years of the old and less than 12 years of the old. If the patient is less than 12 years of the old, albuterol nebulizer solution in the concentration of 0.15 milligram per kg every 20 minutes for 3 doses, 0.15 to 0.3 milligram per kg, maximum dose up to 10 milligram every 1 to 4 hours as needed. And if the patient is more than 12 years of the old, 2.5 to 5 milligram every 20 minutes for the 3 doses, or maximum dose up to 10 milligram every 1 to 4 hours as needed. Albuterol is also available in the meter dose inhaler form, and generally one puff of the meter dose inhaler includes 90 microgram of albuterol. If the patient is less than 12 years of the old, in patients in severe distress, nebulization is preferred. So if the patient is less than 12 years of the old, do not use meter dosed inhaler, because due to meter dose inhaler, if the patient in severe distress condition, the exact therapeutic dose not able to deliver to the bronchial smooth muscle. That's why in the patients or children's less than 12 years of the old, use nebulizer. And if the patients are more than 12 years of old, 4 to 8 puffs every 30 minutes up to 4 hours, and then every 1 to 4 hours as needed. Next example is levolbuterol, which is also beta 2 agonist, from the category of short acting beta agonist, beta 2 adrenergic agonist. Levolbuterol available as nebulizer solution in the concentration of 2.5 milligram per ml, 1.25 milligram per 3 ml. If the patient is more than 12 year of the old, give at one half the milligram dose. And if the patient is less than 12 year of the old, give at one half the milligram dose, same therapeutic dose. Anticholinergic drugs, which are bronchodilators, these drugs act on the muscarinic 3 receptor, and we can say it blocks the muscarinic 3 receptor in the bronchial smooth muscle. So anticholinergic, we can say it's an anti-muscarinic agents. There are also two categories of anticholinergic drugs: short-acting and long-acting. Short-acting anti-muscarinic, or we can say short-acting muscarinic antagonist, are ipratropium, and the long-acting muscarinic antagonist is tiotropium. Ipratropium bromide available as nebulizer solution, 0.25 milligram per ml. If the patient is less than 12 year of the old, 250 microgram every 20 minutes for 3 doses, then every 2 to 4 hours as needed. And if the patient is more than 12 year of the old, 500 microgram every 30 minutes for 3 doses, then every 2 to 4 hours as needed, because the short acting drug, the duration of action is near about 4 hours. Ipratropium is also available as MDI, meter dose inhaler. Ipratropium bromide available in the salt form bromide, and one puff contain 18 microgram of ipratropium. If the patient is less than 12 year of the old, use 4 to 8 puffs as needed every 2 to 4 hours. And if the patient is more than 12 year of old, use 8 puffs every 20 minutes as needed up to 3 hours. So these are the bronchodilators used in acute severe exacerbation of asthma in emergency department, include inhaled beta agonist and anticholinergic. The role of corticosteroid: prednisone and the prednisolone, which are available oral tablet, and methylprednisolone, which is available intravenous shots. If the patient is less than 12 year of old, 1 milligram per kg in 2 divided doses until peak expiratory flow is 70%. And if the patient is more than 12 year of old, 40 to 80 milligram in 1 or 2 divided doses until peak expiratory flow reaches 70%. As we know that the corticosteroids having anti-inflammatory and anti-allergic activity. So in the emergency department, for the management of acute exacerbation of asthma and status asthmaticus, we need the use of corticosteroid. But here, the use of corticosteroid is only by oral and intravenous. But please remember, in the management of chronic asthma we are using inhaled corticosteroids. We are using, and we can say preferring inhaled corticosteroids. And the examples of the inhaled corticosteroids including budesonide and fluticasone. Now we discuss the management of acute exacerbation of asthma, or we can say status asthmaticus. Let us see the management of chronic asthma in the children 0 to 4 years of age. And here the step-by-step approach is very important. The step-by-step management is very important. I will show you the steps. Yes. Now, this steps diagram illustrations will help you to understand which medications in preferred in each steps. Now, if you see the illustrations, there are 6 steps. 1, 2, 3, 4, 5, 6. And there is indications here, step up if needed. Means if the patient on the step 2 and not getting significant benefit, then and then step up, proceed to the next step if the significant benefits not achieved in that step. Plus, it is very important, check the adherence to the medications. In the most of the cases, the adherence to the medications is not proper. Patients are not taking suitable quantity of the dose and the at the right time, and thereby the therapeutic efficacy will not achieved. And then if the patient jump in the next step without the adherence, there may be the chances of the adverse effect. And plus, check environmental control. The environment should be free from the allergic and trigger factors which are responsible for the bronchospasm or asthma. These illustrations divided into 2 therapies for the intermittent asthma and persistent asthma. Persistent asthma needs daily medications. So if the patient experience intermittent asthma, generally the step 1 medications are used, and preferred one is saba PRN, that is short acting beta agonist, and PRN when needed. As the terminology indicate, intermittent asthma, if the patient feels the bronchospasm, difficulty in breathing, use short acting beta agonist as needed. For the persistent asthma, there should be the daily medications. But for intermittent asthma, as needed. In the persistent asthma in children 0 to 4 years of age, the preferred medication is low dose inhalational corticosteroid. And the low dose inhalational corticosteroid includes fluticasone and budesonide. We already discussed all the drugs in our previous lectures. If the patient is hypersensitive or not responding to the inhalational corticosteroid, if the patient is hypertensive, or sorry, if the patient is hypersensitive to the corticosteroids or contraindicated to the use of the corticosteroid, then there is an alternative medications, montelukast, and the which is leukotriene receptor antagonist. So in the step 2, the preferred medication is low dose inhalational corticosteroid, and alternative medication includes montelukast. Stick on the steps 2. If the patient get benefit, step 2, continue the medications on the step 2. But if the patient did not get benefit on the step 2 medications, then if the patient is not getting benefit on the step 2 medications, then the patient should jump on the step 3 medications. In step 3, the preferred drugs are medium dose inhalational corticosteroids, including budesonide and fluticasone. What is the difference between the step 2 and the step 3? In the step 2, we preferred low dose inhalational corticosteroid, and in the step 3, we are using medium dose inhalational corticosteroid. So the role of inhalational corticosteroid in the management of persistent asthma in children 0 to 4 years of age is very important. If the patient get benefit on the step 3, continue the medication. And if the patient did not get benefit on the step 3 medication, then patient can jump to the step 4. And the preferred medication in the step 4 is medium dose inhalational corticosteroid and means plus addition plus either montelukast or long acting beta agonist. So in the step 4, there is addition in medium dose inhalational corticosteroid, either montelukast, which is leukotriene receptor antagonist, or long acting beta agonist. The examples are salmeterol. But please keep in mind that long acting beta agonist did not used as a monotherapy in the management of bronchial asthma, because monotherapy only with the long acting beta agonist may increase asthma related death. So generally, long-acting beta agonist should be prescribed with corticosteroid to reduce the asthma related death. Very important note. If the patient on the step 4 get the benefit on the medications, stick on the step 4. If the patient did not get benefit on step 4 medication, then jump to the step 5. What are the medications at the step 5? High dose inhalational corticosteroid. Now, what is the difference between 2 to 5 step? We used low dose in the step 2, in the step 3 and 4, medium dose. Now in the step 5, maximum high dose inhalational corticosteroid and means plus addition either montelukast or long acting beta agonist. So what is the difference between step 4 and step 5? Is only the dose. In the step 4, there is a medium dose inhalational corticosteroid, and in the step 5, the high dose maximum therapeutic dose inhalational corticosteroid in addition to the montelukast and long acting beta agonist. If the patient get benefit on the step 5 medication, stick on it. If the patient did not get benefit on the step 5 medications, then jump to the step 6. Step 6 includes, and the preferred medications for the step 6 are high dose inhalational corticosteroid and means plus either montelukast or long acting beta agonist and plus addition oral corticosteroids including prednisone and prednisolone. So what is the difference between step 5 and step 6? In the step 5, we already given high dose inhalational corticosteroid and montelukast or long acting beta agonist. The addition drug in the step 6 is oral corticosteroid, that is prednisone or prednisolone. Here, step down if possible, and asthma is well controlled for at least 3 months. If the patient is on step 6 medications and his asthma is well controlled for at least 3 months, then he can jump step down. After step down, after step down, if his asthma is controlled for at least 3 months on step down medications, then he can again step down if possible, and if his asthma is controlled at least 3 months on the step down medications, then he can again step down again if his asthma is controlled at least for 3 months on the step down medications. He can again step down, and if he get benefit on the step down medications, he can follow and stick the same step And most important, patient education and environmental control at each step is most important point. So this illustration explain the use of medication step by step in intermittent and persistent asthma. Same mentioned here with the examples: chronic asthma management with the examples: short acting beta agonist albuterol, levoalbuterol; low doses inhalational corticosteroid in the step 2, budesonide, fluticasone. Alternatives are leukotriene receptor antagonist, montelukast, and zapirlukast. Theophylline is generally used as an respiratory stimulant. Step 3 medications include medium dose inhalational corticosteroid. Step 4, same with the long acting beta agonist formoterol, salmeterol, and oral corticosteroid in the step 6 include prednisone and prednisolone. So these are just the expansion with example, expansion of the long forms with the example for your review. Now, as we discussed in the children 0 to 4 year of age, what about the children 5 to 11 years of the age? What is the difference between the drugs which are used in the children 0 to 4 year of age and the drugs which are used in the management of asthma in the children 5 to 11 years of age? Let us see. Let us just overview the drug. If there is a intermittent asthma, short acting beta agonist as needed, okay. Low dose inhalational corticosteroid. Here there is only addition of theophylline or theophylline, which is respiratory stimulant, or we can say CNS stimulant category. Inhalational corticosteroids, there is addition of the theophylline. LTRA means leukotriene receptor antagonist, theophylline, and here oral corticosteroid and theophylline. So the big difference between the drugs which are used in the management of asthma in children 0 to 4 year of age and in the children 5 to 11 years of age is just the medication, one medication, and that is theophylline. In the management protocol of 5 to 11 years of the age children, there is addition of one drug, theophylline, instead of the leukotriene receptor antagonist. We can use theophylline, and remember the theophylline has dual role. This is the only drug which is having the two properties. First one is a bronchodilator and second one is anti-inflammatory. So from the research study, it was found that the theophylline having two effect, therapeutic effect in the patient of asthma. The first one is a bronchodilator, and second one anti-inflammatory. So this is the main difference between the prescriptions of asthma in children 0 to 4 year of age and 5, 5 to 11 years of age. The difference is theophylline.